Good morning. This meeting of the Baltimore City Council, the Health, Environment, and Technology Committee is now called to order. I am Danielle McCrae, Councilwoman representing the 2nd District and Chair of the committee. In attendance, we have Councilman Ryan Dorsey, representing the 3rd District. We have Councilman James Torrance, representing the 7th District. And Councilman Isaac Yitzi-Slifer, representing the 5th District. Also in attendance from the Mayor's Office is Sophia Gabrin-Hewitt, and thank you, and also Preston Lewis from the Council President's Office. We do have an excused absence for Committee Member Felicia Porter today. And also we have representing in attendance our Matthew Peters, who is staff to the committee. Before we get started, I'm just going to ask that everyone turn off or silence your cell phone. Also, if you have joined us in the council chamber and you would like to testify for any of these hearings, there's a sign-in sheet in the back of the room. We're asking that you sign in and check the box to indicate that you wish to testify. Today, the committee is holding hearings on LO 22-0026, Legislative Oversight Hearing, Monkeypox Vaccination and Outreach Plan, and Resolution 21-0003R, Informational Hearing, Baltimore's COVID-19 Vaccination Plan. We are going to start with LO 22-0026 for the purpose of inviting representatives from the Baltimore City Health Department, Baltimore's healthcare community, and other interested parties before the Baltimore City Council to discuss Baltimore's monkeypox vaccination and outreach plan. For this hearing, we are going to start with brief opening remarks, and then we're going to have a presentation from the Health Department. Committee members will have the opportunity to ask questions after the presentation, and then we're going to open it up to public testimony if there's anyone joining us. In May of 2022, several clusters of human monkeypox cases were reported in countries that do not normally report human monkeypox, including the United States. On June 16, 2022, the Maryland Department of Health identified its first presumed case of human monkeypox virus infection in an adult resident from the National Capital Region. As of September 12, 2022, the Centers for Disease Control reported 21,985 total cases in the U.S. In Maryland, 571 total cases have been identified, with 171 cases, which is 29.9%, in Baltimore City. The total of Maryland residents vaccinated is 4,173. It's critical that as our city grapples with multiple pandemics at once, our residents have access to the latest factual reports, general virus information, harm reduction strategies, vaccination and testing, and support. And it's also of the utmost importance that our messaging and communication is inclusive of all and does not inadvertently isolate or stigmatize already marginalized communities. The monkeypox virus has the capability of impacting us all, and we are all susceptible to possible exposure and contracting the virus. I want to thank Commissioner Jaraza, the entire health department, and our greater medical community, and all who are tackling this virus head on and ensuring that our residents have all the needed resources to reduce their chances of exposure. At this time, we're going to start with a presentation from the health department.
Great, thank you, Chair McCrae and other committee members. My name is Dr. Letitia Jaraza, and I'm the Health Commissioner for Baltimore City. I'm here today to talk about our monkeypox or MPX response. I'll tend to use them both interchangeably throughout, as well as talk about our COVID response efforts. As the chair noted, I will be beginning with a discussion on MPX. I also just want to thank and shout out my team that's here behind me, members of the health department who are so instrumental in this work. So this is just our general disclaimer slide that the data that's being presented today on MPX is up to date as of September 9th. Briefly, this is our agenda for this portion of the discussion. I'll provide a timeline and data review on monkeypox or MPX. I'll review MPX disease characteristics. I will also discuss our strategy and approach for our response, and then close out with some resources. As Chair McCrae noted, when we think about the timeline of MPX, the first U.S. case was discovered in Massachusetts on May 17th, With the subsequent first case in Maryland being discovered on June 16th, the CDC activated their Emergency Operations Center on June 28th. The World Health Organization declared an MPX outbreak to be a public health emergency of international concern on July 23rd. And the U.S. Department of Health and Human Services declared MPX as a public health emergency on August 4th. As of May 9th, there are 171 cases in Baltimore City, accounting for about 30% of all Maryland cases. There are 571 cases total across the state that have been confirmed. The demographics of Baltimore City cases are as follows. Approximately 90% of those cases are between the ages of 20 to 49. 49% of those cases are between the ages of 30 to 39. 71% are Black, and 17% are white, with 8% being Latinx. 92% of the cases noted are in men. Shifting gears to discuss more about the signs and symptoms of monkeypox or MPX. As background, MPX is a member of the orthopox virus family. It is related to smallpox and has no relation to chickenpox. MPX often presents as a rash, usually within 3 weeks of exposure, and flu-like symptoms. This includes or could include fever, chills, swollen lymph nodes, malaise, exhaustion, muscle and body aches, headache, and respiratory symptoms. Those symptoms are usually self-limited. However, the rash can be painful, and individuals can experience all or just a few of those symptoms. Of note, the rash associated with MPX can last 2 to 4 weeks, during which time it's believed that that individual is infectious or able to spread the disease. Individuals may start with the rash first or flu-like symptoms first, with the rash developing 1 to 4 days later. MPX disease can be more severe in immunocompromised folks, children under the age of 8, individuals with eczema or dermatitis, and pregnant women. The pictures on this slide represent different visual manifestations of the rash caused by MPX in different races. So transmission of MPX is thought to occur through direct contact with a MPX rash, scabs, or bodily fluid from a confirmed MPX case. This can include touching objects or fabric used by someone with MPX or close contact with respiratory secretions from a MPX case. Other examples of intimate contact that could lead to spread of MPX includes genital contact, hugging, kissing, massaging, or cuddling with someone who has MPX, and prolonged face-to-face contact. The CDC is still studying the likelihood of transmission between the time someone is exposed to the time they go on to develop symptoms. In the event of a positive MPX diagnosis, it's important to understand how to reduce your risk of spreading MPX to others. Isolation is advised from the onset of symptoms or the onset of a diagnosis being made until that rash is healed and a new layer of skin is present. As noted earlier, this could take 2 to 4 weeks. The CDC has provided graduated recommendations for isolation based on an individual's living situation. Infection prevention recommendations are similar to that of COVID, which includes wearing a well-fitting mask at home around others, using a separate bathroom, using EPA-approved cleaner to disinfect high-touch surfaces, not sharing eating utensils or items that come into close contact with the skin of others. There are currently no quarantine requirements for individuals who are exposed. However, we do recommend that those folks self-monitor for symptoms for 21 days and seek evaluation by a healthcare provider if symptoms do develop. Scientists are still researching if the virus can spread when someone has no symptoms, how often it's spread through respiratory secretion, and if it can be spread through semen and vaginal fluids. However, what we do know about MPX, as with other communicable diseases, implementing prevention measures remains key. So this includes avoiding close skin-to-skin contact with individuals who have a rash that look like MPX, such as might occur during sex, kissing, cuddling, or rubbing, avoiding contact with objects and materials that a person with MPX has used. This includes bedding, sheets, clothing, and food utensils, and certainly washing your hands often to prevent spread of MPX and other communicable diseases. We also know that during this current MPX outbreak, some populations are at higher risk than others, specifically individuals who identify as gay, bisexual, or men who have sex with men, as well as transgender or gender-diverse individuals. However, to be clear, anyone regardless of gender identity or sexual orientation is at risk if they have been in close contact with an identified MPX case. So even though vaccination has certainly received a lot of attention, and rightfully so, it's important to also remember that the city's response includes a robust and comprehensive approach that includes testing to identify cases, case investigations with isolation of those cases, contact tracing, and effective education around prevention, specifically focused on the highest risk population. A robust response must incorporate all of these elements in order to be successful. So given what we know about the highest risk populations, our messaging has been very focused on reaching those individuals. This includes utilization of social media with posting a response to frequently asked questions by our infectious disease clinicians, updates to our website to include information on MPX, and grassroots door-to-door canvassing to spread the messaging among CBOs and LGBTQ-focused organizations and venues. Additionally, Health held a press conference alongside our partner, Chase Brexton, in late July around vaccinations. Subsequent press releases around vaccine supply and distribution have been released as well. Health also had held a number of briefings with council members to discuss our ongoing response. We have met with a number of key stakeholders, including schools and daycares, colleges and universities, and businesses around MPX prevention efforts and infection control. Lastly, Health has been actively engaging our healthcare provider community as a key stakeholder around the importance and need for testing, access to treatment, and plans for vaccine allocation and distribution to those healthcare providers serving high-risk residents. Early disease identification is also a very important part of the city's response. Testing for MPX involves a swab of the rash, lesion, or crusting from the rash. Nationally, we know that many commercial labs are offering testing. The health department is serving as a safety net provider with access to limited testing for those who may not have a primary care provider. We're also, as I mentioned, educating those local providers on how to test their own patients. Additionally, we conducted a survey sent out to local providers, and so far we've received 11 responses, 5 from emergency departments, 3 from outpatient clinics, 2 from federally qualified health centers, and 1 from an urgent care. 9 of those 11 are offering testing. Case investigation and contact tracing are also a key part of our response. Similar to COVID, when an MPX case is identified, our team interviews and educates those cases on infection prevention. We also notify close contacts, offer vaccination, and educate those close contacts on what symptoms to look for. We have identified isolation support for MPX, those living with MPX that might be unstably housed, and are working through the contract and procurement process to finalize a contract with that vendor. We're also working with the Mayor's Office of Homeless Services and the Mayor's Office of LGBTQ Affairs on additional supports for residents that need to isolate in place. This slide provides an outline of the U.S.'s MPX vaccine strategy. The focus is really to identify individuals at highest risk for disease and provide them with vaccination as supply and distribution allows. Individuals with a known or presumed exposure to someone with MPX are eligible for what is called post-exposure prophylaxis, or PEP. Individuals with certain risk factors and recent experiences that make them more likely to have been recently exposed to MPX are also eligible for what's called expanded post-exposure prophylaxis, or EPEP. The last category of eligibility identifies those that are at risk due to being a part of certain occupational groups, such as lab workers, and it identifies those folks prior to potential exposure, providing pre-exposure prophylaxis. As noted, the health department's eligibility criteria is based on the CDC strategy as vaccine supply and distribution supports. Specifically, when we think of that extended post-exposure prophylaxis, or EPAP, this is individuals who've had sex with multiple anonymous partners in the last 14 days and identify as being gay, bisexual, or other men who have sex with men, or transgender women, transgender, gender nonconforming, or gender non-binary individuals, and sex workers who are engaged in any type of survival sex, regardless of sexual orientation or gender identity. The CDC is not encouraging mass vaccination for the general public or for all sexually active people. The vaccine itself that is being used by the health department is called Jynneos. It is a 2-dose vaccine given 28 days apart. On August 9th, the vaccine was approved to be administered to children subcutaneously and approved to be administered to those 18 and over intradermally. For reference, subcutaneous vaccines are given in the fat layer underneath the skin, while intradermal vaccines are delivered into the dermis, or skin layer just below the epidermis, that top superficial layer of our skin. For intradermal, think your TB test that we all used to get for school. For subcutaneous administration into a fat layer, think of administration of insulin. The health department is administering the vaccine intradermally per the state's guidance. Intradermal administration does help with increasing current vaccine supply by increasing the amount of doses that can be given per vial from 1 dose per vial to now potentially 3 to 5 doses per vial. The health department does have a limited vaccine supply and limited capacity. Subsequently, our focus has been on equitable distribution with the vaccine supply that's available. This has involved direct canvassing to high-risk groups and offering EPEP appointments at high-risk venues and through the health department's and Chase Brexton high-risk STI clinics. We have additionally set aside doses for identified close contacts and at-risk healthcare workers. We are also establishing a vaccine allocation and transfer program with Ryan White providers who service those living with HIV, other HIV care providers, FQHCs, and other clinics across the city. We actually convened this group of over 17 partners yesterday to review the process and discuss next steps for vaccine distribution directly to these partners. As noted previously, the health department is following the U.S. and state vaccination strategy. In phase 1, we started vaccinating close contacts of cases. Vaccinations of those close contacts will continue throughout all of the additional phases moving forward. In phase 2, we were one of the first jurisdictions to identify individuals meeting that expanded post-exposure prophylaxis criteria and started an EPEP vaccination campaign. We held 3 clinics. For the first one, our staff conducted street outreach among members of high-risk groups to make appointments, and individuals received vaccines through one of our partners, Chase Brexton. 59 individuals received a first dose during this first campaign, and 52 received their second dose. We also held 2 clinics that were open to the public at our STI clinics and vaccinated 80 individuals. Registration was open to the public, meeting EPEP criteria, and they were available over the phone. These appointments were available over the phone in hopes of providing vaccination appointments to those who may lack internet access. We understand that demand was very high, and our infrastructure made it frustrating to schedule some of those appointments. Subsequently, we are working on increasing our capacity. So we've started vaccinating more eligible patients through our STI clinic and continue to work with Chase Brexton. Both us and Chase Brexton have 2 of the highest rates of STI diagnosis in the city, which we know is an important indicator of risk. We're now moving into phase 2B. In this phase, we're expanding our efforts to distribute vaccine to additional clinical partners. As mentioned, this includes our Ryan White clinics, our federally qualified health centers, our providers serving high-risk patients, and other community clinics. We will continue to evaluate our internal capacity to expand vaccine distribution after our initial reallocations to these groups are made. In addition, we're pursuing contracting services to expand our capacity to provide MPX vaccine, and we're continuing to vaccinate our patients that we know are high risk. So these are just some of the numbers reflecting the number vaccinated in the city using health department vaccine supply. First, I'd like to note that, as I mentioned, in the past 2 weeks, we shifted from subcutaneous to intradermal, where it used to be that 1 vial was equal to 1 dose, and now we're getting multiple doses per vial. So this increased our vaccine supply. We had to shift how we were reporting, and our inventory processes do reflect this change. Moving forward, we're working on reporting the data directly from Immunet, the state's vaccination record system, to reflect a more comprehensive assessment of the number of residents vaccinated. The data presented here is only reflective of vaccines that we've provided and doesn't include residents who may have been vaccinated at other locations in and out of state. In early September, the State Health Department opened a pre-registration portal for MPX vaccine. This can be accessed online, and it does require that an individual answer questions related to vaccine eligibility. The health department can pull city residents from a pre-registration list, review eligibility, and schedule those individuals for vaccination as supply allows. Around 500 city residents have registered so far, and once we obtain the contracted support, we plan to host clinics to vaccinate those eligible individuals identified from the list. This will remain a portion of our strategy, but certainly won't replace the grassroots direct outreach into impacted communities and our ongoing provider support. Rounding out the MPX discussion with treatment options, the primary treatment is a drug called tecovirimat, also known as TPOXX. This treatment was developed to treat smallpox and has received special approval for use against MPX during an outbreak. Treatment is focused on those with a compromised immune system at risk for complications from MPX. There is some limited availability for treatment at the health department and other clinics across the city. This is just a list of some of the resources. Includes our website, includes the state's website, as well as CDC, and guidance that can be provided to schools, daycares, colleges, and congregate settings. So I can go straight into COVID. I don't know if we wanted to take a break.
We're going to take some questions, and then we'll take a brief pause, and then we'll come back to the COVID presentation.
Sounds good.
Thank you. We have been joined by Councilman Conway.
Thank you, Madam Chair.
And I'm just going to start with a few of my questions. Bear with me just a moment. So the first item is that we know that skin-to-skin contact is driving transmission. Medical briefings and experts, including within your presentation, have highlighted items such as like certain linens or clothing with someone who had or has had lesions can also drive the spread. What is the prevalence, if any, of respiratory transmission?
Yeah, I'll start, and then certainly I have Assistant Commissioner Dr. Greenbaum, who is an infectious disease physician, to chime in as needed. But I will say I think the CDC is still evaluating that, like what is the most kind of prominent or prevalent form of transmission, or how prevalent it is as a result of respiratory secretions. Like you said, we know that it can occur. I don't know that we know the exact prevalence or likelihood of it occurring through those contact points.
Okay, I saw the thumbs up. The CDC has noted that a pregnant person can spread the virus to their fetus through the placenta. Talk to me about the health department. Have you all taken any efforts to specifically educate our pregnant and parent population on a potential impact of contracting the monkeypox virus on a fetus?
Yeah, I think that's a great question. I mean, our outreach certainly has been particularly focused on other higher risk groups, such as men who have sex with men. But certainly this is something we can incorporate more into our messaging.
Okay, have you guys had any type of communication with Be More for Healthy Babies about a strategy regarding this item?
I do. We actually have our Assistant Commissioner for Maternal and Child Health, and so she is very engaged in our message development. So certainly, again, great idea. We can use that network to spread that information.
Okay, so did you want to just talk to us about any of the communication that's happening with Be More for Healthy Babies at this time?
Good morning. I'm working with Dr. Greenbaum closely to make sure that we get anything out.
I just need your name.
Oh, I'm sorry, Rebecca Deneen, Assistant Commissioner for Maternal and Child Health. For Be More for Healthy Babies, we've been focused a lot on the COVID vaccine right now, but I'm waiting for messaging to work with Dr. Greenbaum to make sure that we get something out, but we have all sorts of channels to do that. And I think they've been focusing on other high-risk populations, but that is an easy dissemination process within the next couple days.
Okay, thank you. Did any of the members have any specific questions? Okay, well, I'm going to keep going. I have a ton of questions. So the CDC has shared that people who are infected can spread the monkeypox virus to animals and vice versa through various methods of close contact. I know that we're focusing on like high-risk populations, but is any information being provided to animal control, which is within the health department, just communicating with owners of licensed pets about potential human to animal transmission and any of the CDC's recommendations?
Yeah, so I know when we have cases that have been identified, part of the education that's provided to them is the ability to spread to animals. We've not necessarily gone directly to animal control. It's really been focused on those identified positive cases, so that they know certainly mechanism of potential spread, but that it can be spread to animals as well. So it's been more focused on those identified positive cases.
Okay, thank you. The next thing I want to get into, you mentioned within the presentation, I didn't take down the exact number, but if you could tell us how many doses of the vaccine the health department is receiving, what percentage of the total amount, if you know, distributed by the state, does that represent for the city? And is that sufficient to meet the city's needs?
Great question. So there is a slide, I think it's 19. Total vials received, and again, remember this is vials, but there may be more doses now, are 725. That's what we received from the state to date. Total vials allocated, so this includes what we're giving as well as what we're distributing or reallocating to partners, is 689. If you recall, we do hold back a certain amount for those identified close contacts. I would have to follow up on what percentage of this total state allocation that is. I do not know that off the top of my head, but we can certainly get that information for you. As far as it being enough, I think we had a really great meeting with multiple providers across the city. So, again, vaccination is a component of our response, and I think it's really critical that we continue to work with healthcare partners who are embedded and working closely with the high-risk population to help us with kind of distribution and vaccination across the city. Again, because we have many providers who are embedded, Ryan White providers, federally qualified health centers that can more easily be accessible to the same residents that we're also trying to reach.
I'm going to pivot just quickly to the response. You laid out multiple steps within this response, but can you talk just more about what does contract tracing look like in this case?
Sure. So I can start. I may have my team chime in. I do liken it somewhat to COVID because I think people are just familiar with what case investigation and contact tracing looks like from that perspective. So any positively identified case in Baltimore City, we reach out to that person, our contact tracers reach out to that individual. We help them or we ask them who their close contacts are, so that we can notify those close contacts. We also provide them with information or education on how to reduce spread, right? So if, again, similar to that, isolation and what a person needs to do when they're positive for COVID, we lay out that information so that they can safely isolate away from others that could be exposed, in addition to notifying their close contacts. So I think that, one of the things that we've heard as feedback is really making sure that those folks also have additional support and resources. This was the same with COVID. And so that's why I think our partners in the Office of LGBTQ Affairs in MOS is really critical to help support some of those social needs. But I would liken it very much to COVID, just making sure a person understands when they're infectious, how they can spread it, making sure they isolate during that time, and then working with their close contacts. And when possible, getting those close contacts vaccinated if they're interested. That is a role that we play as well.
Okay, and for my last question, as of September 9th, Maryland's black, the entire state, black population made up 57.6% of cases. And according to CDC data, black and Hispanic populations have been hit the hardest across the country. What factors do you believe are contributing to these two communities being hit the hardest by the virus?
Yeah, so maybe I'll start, and again, maybe Dr. Greenbaum has insight as well. So I think we certainly know the higher risk population that we serve here in the city. is predominantly Black, which is why we may be seeing a slight skew towards more African Americans. Internally, we discuss this, and we discuss, is there also maybe a testing bias, right? And so folks who are accessing care through our clinics, through Chase Brexton, through others, are more likely to get tested, and that is the population that we serve, so perhaps we're identifying it more in that group as well. I think it's just also important to note that with many diseases that we do see these types of disparities just because of socioeconomic challenges and the general social determinants of health.
Hi, my name is Adina Greenbaum. To build on what Dr. Jaraza mentioned, given what we're seeing about transmission of MPX right now and how it's being transmitted, even though it's not a sexually transmitted disease, or at least that, that's something that the CDC is continuing to look into more, it's spread via sexual transmission networks, because we're seeing it spread via that close contact that occurs during sexual behaviors. So some of the patterns that we're seeing in the epidemiology are mirroring what we see in our HIV epidemiology in the city, the state, and the region, and also the epidemiology of sexually transmitted infections like chlamydia and gonorrhea. So some of this is mirroring what we see for diseases that are spread in similar transmission networks, and that and we see similar disparities and health impacts in HIV and STIs is what we're seeing in MPX.
I appreciate you. Can you expound upon, I know that you're working with different agencies. You mentioned two of them, but how are we ensuring, can you speak more about how we're ensuring that equity, there is equity in vaccinating eligible Baltimore City residents, and just ensuring that there's equitable access to the information?
Yeah, great question. So I'll maybe start with the information piece. I think early on, once we knew who the highest risk population was, our focus was really on grassroots canvassing to those CBOs and to those LGBTQ serving populations, right? And so, certainly understanding social media is an element of that, and we've done that too, but also recognizing that door-to-door direct person-to-person outreach or direct health department to organization outreach is critical. We luckily, I think through COVID, strengthened many of those partnerships and relationships, so did a lot of that direct education. Additionally, we did more of the broader forms of education, so social media, posting FAQs from our infectious disease clinicians online, on Instagram. Additionally, working with providers who are serving this community. I think we cannot overstate the importance of the healthcare provider community and also being messengers around prevention. And so making sure that they feel comfortable sharing the messaging, that they feel comfortable testing their patients, that they understand how to access treatment as well if needed. And then I think the other question was around equitable vaccine distribution. And so, I mentioned that our focus has really been, again, those high-risk groups that are typically underserved. So I think that's where our STI clinics and Chase Brexton clinics are critical. We know, as Dr. Greenbaum mentioned, these particular social networks, these clinics have some of the highest STI rates in the city. And so we know that we're already capturing that high-risk population by going through these channels. We're now beginning to engage additional providers across the city who serve this high-risk population. When we did those events, it was a combination of both canvassing and outreach to talk about the event, but we also set up a call line, right? So recognizing that internet access is not available to everyone. So making sure we had that call line for people to call in to schedule appointments as well.
Okay, a last question on this one. The CDC warned in a health alert last month that preliminary evidence suggests that children younger than 8 could develop more severe illness if infected with monkeypox. Is there any engagement? I know you had a convening yesterday, but what does engagement look like with the health department and the city and city schools?
Oh, great question. So I never stopped meeting with city schools around COVID, and so a lot of those meetings, we talk now about both, and so making sure that city schools understand some of the kind of infection prevention measures, which, as I mentioned, there's some overlap and similarity with COVID, and so I think city schools does have much of that infrastructure in place of how to kind of protect folks and protect kids and students. And so we've been discussing that now for the past few weeks. We're working with city schools on additional messaging to go to school leadership. Again, we think right now there is a lower risk in children, but certainly we're planning for how to make sure that city schools and staff are prepared.
Okay. And it looks like those are the questions for this particular hearing. We do not have any public testimony on this particular item, so we are going to take a brief did you have a question? Okay. We don't have any public testimony, so we're going to recess this particular hearing, and we're going to come back in about 3 to 4 minutes just so we can get an update on COVID-19. Thank you. We are going to move on to Resolution 21-0003R, Informational Hearing, Baltimore's COVID-19 Vaccination Plan, for the purpose of inviting representatives from the Baltimore City Health Department, Baltimore's healthcare community, and other interested parties before the Baltimore City Council to discuss Baltimore's COVID-19 vaccination plans. The committee held a hearing and several follow-up meetings on the resolution over the last year and a half. Today, we're going to hear an update from our health department on current COVID-19 data and our progress vaccinating Baltimore City residents. After that, committee members will have the opportunity to ask any questions, and then we will move on to public testimony if there is any. First, I do want to again thank our Commissioner, Jaraza, the entire Baltimore City Health Department, and again, our greater healthcare community in their collaborative efforts to tackle the COVID-19 pandemic for over 2 years now. While the COVID-19 pandemic has evolved over time and vaccinations and testing have become more readily accessible, we do continue to deal with its overarching impacts with the flu season fast approaching and the prevalence of monkeypox silently impacting our city. It is crucial that we all have a greater understanding of ongoing strategies, recent trends and recommendations, and vaccination efforts so we can ensure that our residents are still able to make informed decisions to keep themselves, their families, and our community safe and healthy. At this time, we're going to start with our commissioner's presentation.
Good morning again. My name is Dr. Letitia Jarasan. I'm the Commissioner of Health for Baltimore City. As noted, I'll now be talking about our overall COVID response. Disclaimer slide, as always, just to indicate that the data being presented is up to date as of September 12th. Quickly reviewing our agenda, I will begin with data updates followed by vaccination and testing updates. I'll also discuss our ongoing approach to case investigation and contact tracing and round out with a quick discussion on long COVID. So beginning with COVID cases over time and our general data updates, this graph represents new cases over time by report date. Negative numbers and the spike after the Omicron surge in early 2022 are due to data corrections made by the Maryland Department of Health. Presently, daily counts of new cases are slightly decreasing. We're currently averaging 116 new cases per 100,000 residents in the past 7 days. This figure shows COVID hospital admissions over time in Baltimore City hospitals in both the ICU and acute care settings combined. As you can see, hospitalizations, which we call a lagging indicator, are at a moderate level currently. We're now averaging about 10.3 new COVID-related hospitalizations per 100,000 people in the past 7 days. Here we see the number of COVID deaths by report date over time. Negative numbers and the spike in May 2021 are due to data corrections by the Maryland Department of Health. Deaths increased during the Omicron surge and have noticeably slowed since then. The flat part of the graph in December 2021 and January 2022 represents missing data that occurred during the MDH cybersecurity incident. What I just reviewed is where we currently stand with COVID-19 metrics. We were also asked to discuss how Baltimore compared with other jurisdictions. In a report issued by Johns Hopkins in September 2021 that compared Baltimore City with 325 other U.S. counties of similar socio-demographic characteristics between March 2020 and June 2021, Baltimore City fared better than most counties as measured by COVID-19 incidence, mortality, case fatality, and vaccine coverage. For cumulative incidence rates, Baltimore City was lower than 265 of the 326 counties. For cumulative mortality, Baltimore City was lower than 237 of the 326 counties. For cumulative case fatality rates, Baltimore City was lower than 183 of those 326 counties. And for vaccination coverage, Baltimore was higher than 317 of those 326 counties. Switching gears to discuss our COVAX or COVID vaccination efforts. Vaccination remains a pivotal component of our ongoing response. We continue to perform weekly vaccination clinics alongside our partners. All of our clinics are providing third and fourth boosters as recommended by the CDC. Please reach out to specified clinics to confirm they are also providing the newly available bivalent boosters. We have updated and relaunched our COVID-19 vaccination dashboard. The URL is listed at the bottom of the slide. We continue to update this, as well as our Community Statistical Area or CSA COVID-19 vaccination coverage map on a weekly basis. Based on our current dashboard, as of September 6th, 75.5% of residents 12 and up had a first or single dose, while 8.5% of 0 to 4-year-old residents and 34% of 5 to 11-year-old residents had a first or single dose. I do want to note there are some discrepancies on our separate health department dashboard when compared to the broader website coronavirus.baltimorecity.gov. On our vaccination dashboard, we use Maryland Department of Health Immunet data. So Immunet is the state's vaccination record system. On the broader website, which is pulling directly from the CDC, they use Immunet data, but they also use some entities that report directly to them. So for example, the VA would report directly to them. That wouldn't show up in our Immunet data. So that's why we see those discrepancies. So just to be clear, the reason why we are using Immunet data is because it allows us to drill down further into specific demographics, including CSA, ethnicity, race, and age. The CDC data allows us to drill down by certain age groups, but we're not able to get the specifics around CSAs. We are still using this data to drive our strategy, so it is critical that we get as much detailed information as possible. This particular map depicts vaccination coverage at the CSA level through September 5th, with the darkest blue representing the highest vaccination coverage areas and the orange representing the lowest coverage areas for all age groups. The blue and red symbols represent weekly health department supported vax clinics for different age groups. There have been at least one Value Communities clinic in 54 of Baltimore's 55 CSAs since our efforts began. To date, there have been almost 2,400 health department supported or involved COVID-19 vaccination clinics, and almost 62,000 vaccine doses have been provided at these clinics. These numbers do not include our mass vax numbers, and they also don't include the vaccine being given at our 1,200 East Fayette clinic. So our focus this fall is really on outreach and vaccination to portions of the population that were eligible later, specifically children, and residents who have not yet received their first dose of vaccine. This map outlines areas of the city with the lowest vaccination coverage. We actually launched this fall outreach work on Monday, starting with the southwest region of the city, represented by the salmon colored portions on the map. The plan is for the next 6 weeks, community health workers and value ambassadors will first canvass and then support vaccination events and other neighborhood vaccine activities to reach over 17,000 residents in this particular region of the city. Additionally, over a 4-week period, we will focus on the purple portion of the map, or the western regions of the city, with a goal of reaching 11,000 residents. We will also spend time in the northwest parts of the city, represented by the orange in the corner, to reach approximately 3,200 people in a week. And lastly, we'll focus our efforts in the northeast region of the city, represented by the green or aqua color, with a goal of reaching 7,500 residents over 3 weeks. In terms of bivalent boosters, we are offering bivalent boosters at our mobile response sites. We are also transferring a very limited number of doses to other healthcare providers through our vaccine transfer program. We will be providing vaccines at public senior housing sites and at our health department clinics as well. As a reminder, many of our pharmacy partners throughout the city are also providing bivalent boosters that are covered by insurance and get their doses directly from other sources, not the health department. So now on to testing updates. So testing and testing access also remains an ongoing priority for the health department. So while rapid tests are certainly more widely available, we recognize there still remain portions of our population with less overall access to testing. So we're proud to say that we have been doing community testing continuously since March of 2020, with that initial launch of Pimlico and subsequent launches of mobile testing sites. This work is made possible in partnership with many other entities, and we've embedded sites throughout the community. Testing also remains available in the private sector, at urgent care centers, and at State Center. We also continue to distribute rapid test kits. Rapid test kits we know are also available through self-purchase, and most are reimbursed by insurance companies. The U.S. Department of Health and Human Services is also offering another round of test kits to households that request them online. This is just a snapshot of the community testing sites that we held from March 2020 through August 2022. To date, BCHD has conducted testing at close to 50 locations across the city. This graph represents the total number of individuals tested at our community testing sites. The green line represents percents of positives that particular month. We did see a decrease in testing demand after the Omicron surge, and we did see an increase in percent positivities as the total number of tests decreased this past summer, which is also consistent with state data. We've continued to expand our rapid test kit distribution program since launching it in November 2021. To date, we have distributed over 237,000 rapid test kits. This table shows the total test kits provided by each of the arms of the program, and we've built this distribution program to provide the infrastructure needed to support through any winter surges where rapid test kits may need to be distributed quickly. Our partnership with Enoch Pratt Library continues, along with our network of CBOs that distribute test kits to other organizations and directly to the public. This map shows the location of different CBO partners who are distributing COVID test kits, again, through our rapid test kit program. They represent the value communities and distribute those kits to individuals and other organizations. So shifting gears to discuss our ongoing approach to case investigation and contact tracing. With regards to case investigation and contact tracing, or CICT, in June of 2022, the health department underwent a scheduled staff reduction from 120 to 80 staff supporting case investigation and contact tracing. Staff continue to support efforts around case investigation and contact tracing, especially as it relates to outbreaks in congregate settings. Staff are also supporting work with the COVID call center team, and we're updating protocols to prepare for a possible fall-winter surge. Staff are also undergoing training for community health work to support other efforts like the previously mentioned canvassing and education ahead of vaccination events in low-coverage areas. We continue to prioritize our workflows to identify the most at-risk residents who need immediate follow-up. We're focused on monitoring those outbreaks in congregate settings, like nursing homes and like shelter spaces, and we're actively refining those protocols and how individuals can be referred to other support services in the health department and community-based organizations. We also continue to provide public education and outreach through the community canvassing events mentioned, and we continue staff training to prepare for potential winter surge. So briefly, I will discuss post-COVID conditions. Also known as long COVID, long haulers COVID. Post-COVID conditions are defined as new, returning, or ongoing health problems occurring over 4 weeks after being infected with COVID. While we're still learning about long COVID, its symptoms and its implications, we do know that it can include a wide range of ongoing health issues that can last for weeks or longer. The most common symptoms include respiratory issues and musculoskeletal pain, including difficulty breathing, cough, tiredness or fatigue, and neurological symptoms like headache and difficulty thinking or concentrating, just to name a few. We also know that long COVID is found more often in people who had severe illness from COVID-19. However, even those with mild COVID-19 can experience long COVID symptoms. We also know that people who are unvaccinated are at a higher risk of developing these post-COVID conditions. Several large studies indicated that post-COVID incident conditions occur in about 20 to 30% of patients 18 and older. It is critical for those who may have symptoms of long COVID that they work closely with their primary care provider to potentially seek treatment from a range of specialists to help support those ongoing symptoms. That concludes the formal presentation on COVAX.
Okay, thank you. I'm going to go ahead and just get right into questions, and I'll open it up for any other committee members who have questions. First, I just want to review some vaccination information. At the April hearing, you stated that the goal was obviously to vaccinate 80% of 5 to 11-year-old children by September 30th of this year. And according to the vaccination dashboard and some of the data that you shared, we have only 34% of that population who have received their first dose, and that's for first or single dose. 28.4% are considered fully vaccinated. So the first question is, what are the major challenges around getting this specific population vaccinated and meeting this target?
Yeah, so and I'll speak anecdotally. So certainly as a pediatrician and parent, and also as a member of the state's kind of pediatric vaccine group. So we meet bi-weekly to discuss challenges across the state with this group getting vaccinated. And honestly, a lot of what we're hearing anecdotally is that parents believe that children don't become that ill from COVID. And so even some parents who got themselves vaccinated immediately, there are reservations and hesitations to get their child vaccinated because maybe they don't know some of the long-term implications of vaccination in children. And they are, again, under the impression that children don't fall that ill from COVID. So why would I potentially vaccinate them against this? So I think it's been very challenging. Again, that's certainly not just in the city, but really across the state and across the country. I don't know if Assistant Commissioner Deneen has anything to add.
I'll just add that our current fall, Rebecca Deneen, I'll add that our current fall campaign is about, there's two main messages. One is keep children in school. The second is keep people out of the hospital. And so the areas that we selected with our epidemiologists were both areas of the city for this canvassing campaign that had the highest number of people unvaccinated at all, like with no vaccine, but also were areas of the city that had a high number of pediatric kids, 0 to 12 years old, who were not vaccinated. So the idea is that we're going to, with our messaging campaign, we have a piece on the new vaccine, but we also have a piece on long COVID and the fact that young children can also get long COVID, and there's a reason to be concerned about vaccinating them. So it's been, as Dr. Jaraza said, this is a national issue. It's not, we are certainly in line with everywhere else. It's not as though Baltimore City is struggling more than somewhere else. It's really a challenge, and we're trying to do all that we can.
Are we going to be revising the targets or any of these targets?
Yeah, I think that's a good question. I think certainly I'm hopeful about this campaign and its effectiveness, so we can discuss internally based on the data we have if that makes sense. But you know, I think certainly it's something for us to take back and discuss internally.
Okay, well, you answered. I'm going to say you answered. I was trying to figure out what are the disparities between the two dashboards. So you answered that question. You guys just gave me more information about exactly why that Southwest corridor is being targeted first, along with the other areas. I'm going to go ahead and move on to a question related to ARPA. So BCHD, the health department, you guys received $5,245,000 in ARPA funding, which in part would provide 120 contract tracers and supervisors. And at our last hearing, you did note that your agency may be decreasing the number of contract tracing staff in a stepwise approach. So I believe that during the presentation, you guys did state that you shifted from 120 to 80. Is that correct?
That's correct.
Okay. So I know that the contract traces, they do various work, including case investigations, but how will this money be used if we have downsized the number of staff members?
Yeah, so maybe I'll start, and certainly we'll bring up, I think we have Lanisha Childs, who's our Assistant Commissioner over the general COVID response. So again, we do anticipate there to be a fall and winter surge, and so we do think that members of this group will still be needed to support during that time. We do still investigate outbreaks in congregate settings, so our nursing homes, healthcare facilities, homeless shelters. We are still focused on trying to do outbreak prevention among those groups, and that's part of what this group, the contact tracers, do. They also do education and outreach, so I mentioned some of the canvassing efforts, so they do support there and support our COVID call center, but I'll certainly let Assistant Commissioner Childs come up and discuss.
Hello, Lanisha Childs, Acting Assistant Commissioner for COVID mitigation and outbreak response. So just to add to what Dr. Duraza just mentioned, there's been a lot of changes in the follow-up for COVID-19 from a CDC perspective. So we're no longer following up on every contact. We're focusing our efforts on those high-risk contacts and those areas where individuals are living in communal settings. So our staff is spending quite a bit of time working with our shelter systems, with our long-term care facilities, our nursing homes, even our senior housing buildings. Another thing that has changed or shifted since then is the survey that the MDH has sent out a survey, and that survey is going to all positives. So if somebody has an option to complete that same interview via online portal survey or via phone call. So those phone calls that are made to those high-risk patients, and then the follow-up is being kind of shifted to our outbreaks team, our call center team, and we're just dividing the work amongst the three.
Okay, thanks for that information. Commissioner, is that money being reallocated at this time since there was a shift, or is it staying there because you guys have made numerous pivots within the strategy?
Yeah, so I'll say in general, we're looking at ARPA funding and how it's being spent across the department. So a couple reasons for that. So some services are still covered with 90% FEMA reimbursements, and ARPA is covering 10%. So we realize currently that there is underspending. So we are evaluating that any money that could be used and considering budget modifications in partnership with the Mayor's Office of Recovery Programs. Again, that makes sense as we change our response efforts. So yes, that money is being actively evaluated to identify where and how it should be shifted.
How many of we know that you downsizing shifted from 120 to 80, are all 40 of those contract traces, are they have they moved into different roles within the health department?
So I think some of them have, but then some of them, again, there was just transition to other opportunities outside of the health department. And I will add, that was always a planned downsizing, and so that was a part of the original ask to go from 120 to 80. So
what other employment opportunities were provided to these contract traces at the end of their time?
Sure, sure. I'll let Acting Assistant Commissioner Childs come up to discuss.
Okay.
Sorry. Good morning, everyone. Jennifer Martin, Deputy Commissioner for Population Health and Disease Prevention. We actually had quite a few of our 120 staff who started to transition out of the agency actually beginning last September. And so a number of staff moved on to other positions, not only in the health department. We had a few have moved on into the health department, but many who moved on into the healthcare systems and other venues as well. And as I said, so some of that transition actually started in the fall of last year, and then we did reduce to 80 positions beginning on July 1st. Does that answer your question, Councilwoman?
I thank you for the information. We're going to shift to Councilman Torrance, you have the floor. I know you have a few questions.
I just have a request to the agency. Can you provide that breakdown of who stayed in the health department, who moved to other positions, by position as well? I know you can't give me the staff person's name, but if they moved into an external agency, what position did they move in within the health department? And then can we have copies of this plan? Because I didn't know that you were downsizing to 80. My understanding from the conversations we've had with administration that you were going to be at 120. So that shift was not clearly communicated to us as an oversight authority over this. So I would like to understand that plan and the details towards that as well.
Sure, sure. So we can, we can work with our HR team on kind of the numbers that transition. We can pull kind of that original ARPA plan to be reshared with this group as well.
Thank you.
Do we have any additional questions? Okay, so I think this is my last question this time. At our last hearing, you did speak about how the health department works with DHR and the Restoration Services Oversight Committee regarding city employee vaccinations and other COVID-19 efforts. We know that long COVID continues to impact our population, our city employees, and can also just limit an individual's ability to work at full capacity due to a lingering group of symptoms from fatigue, brain fog, shortness of breath, heart and lung damage. What I want to know is, have you worked with DHR and other agencies to establish any type of guidelines on how to respond to our city workers who are dealing with the impacts of long COVID, and how to provide proper accommodations regarding, say, remote work, offering more breaks, handicap access, different things like that? Are you guys a part of that conversation, city workers and long COVID?
Yeah, so we are supporting the city's Restoration Services Oversight Committee, or RSOC, that is led externally by DHR and other agencies. So we do provide guidance as asked. I don't know that we've provided specific guidance around kind of how to support someone with ongoing challenges related to long COVID. Yeah, I don't know that we've done that, but certainly we can reach out to that group to ensure that they have what they need.
Okay. That was my last question, and we're just going to double check to see if we have any public testimony. I don't see any online, and we don't have anyone who signed up to testify. So I just want to thank everyone for joining us. These were two very important hearings that we needed to have. The committee is likely going to hold additional meetings in the coming months just to make sure that our communities are informed about the city's continuing vaccination efforts and progress. And this hearing is now in recess. Thank you.